Good afternoon, classmates and colleagues. I would like to immediately start off by thanking those individuals who will be taking the time out of their busy lives and schedules to sit down and listen to my introduction on multiple sclerosis. Second off, I would like to share the goal of my research here today. And with that being said, following the end of my presentation, I believe that you will all be equipped with the basic immunology and pathophysiology behind the development of multiple sclerosis. And then lastly, I believe that this information is extremely valuable in our everyday social lives, as well as even more so applicable in the development of future professional healthcare workers. So these were the two main reasons to why I chose multiple sclerosis for my presentation. So let's start off. Here's a basic itinerary for today's lecture. I wanted to give you guys a basic idea of where my presentation is headed so you guys aren't wondering. In my opinion, a thorough lesson begins small and works into increasing complexity. So I want to start with the basics of MS and then work towards a more in-depth the immunological aspects of the disease. And then following both a light and in-depth review, I believe that addressing the variety of patterns and symptoms that is involved with multiple sclerosis is very useful to understand. And then to wrap up, I want to share what a real-life experience might be like when seeking treatment for this autoimmune disease, as well as some related research and facts. So let's start off. What is multiple sclerosis? Well, multiple sclerosis is a chronic degenerative disease of the central nervous system, or the CNS. And the CNS is comprised of these two main organs, the brain and spinal cord. MS is actually characterized by lesions on these two here organs, and they're going to actually arise from a variety of situations. So situations being inflammation, infiltration of the blood-brain barrier via infiltration of the blood-brain barrier by immune cells, as well as oligodendrocyte death, or OG cell death. Now let's take a look at myelin and its role in multiple sclerosis. Myelin is actually the protective sheath that surrounds axons between our actual neurons. And myelin is produced by oligodendrocytes, or OG cells, a type of neuroglia found in the central nervous system that's solely responsible for creating this fatty proteinaceous substance. And this substance actually acts as a transmission tool of electrical impulses between neurons. And this is actually how signals and messages are sent throughout our body. The brain and all those fragile components found within the brain happen to be protected from blood antigen via the blood-brain barrier. The blood-brain barrier, or the BBB. Government states that T cell function in a healthy individual will go along the lines of something like this. A T cell will enter the blood-brain barrier via endothelial cell tight junctions, look around for antigen, and then actually leave. But in the case of multiple sclerosis, Haugland and exactly illustrate this interaction of antigen-presenting cells, T cells, and myelin as a CD4 cell-mediated response, resulting in a pro-inflammatory response. And this pro-inflammatory response is actually going to occur after T cell activation and cytokine release, which is going to lead to B cell recruitment, where B cells will actually mark myelin as foreign with antibody proteins, which will in turn recruit macrophages then that will come in and engulf those antibody proteins that are found on the myelin and the oligodendrocytes. Following B and T cell activation and recruitment, Krieger et al. States that these three situations typically occur in multiple sclerosis. In situation one, we see an immune response occurring, inflammation is starting, we see inflammatory cells present, and the recruitment of other immune cells as well. In figure two, we begin to see chronic inflammation as well as OG cells beginning to become terminated and destroyed, as well as those myelin sheaths. But a takeaway from this figure is that those OG cells are not completely killed off, and remyelination is still occurring, or the recovering of myelin is still occurring. In situation three, we actually see the complete termination of OG cells. Plaques are arising far more unpredictably. Sclera are becoming more evident and more prevalent. And as well as OG cell death and myelin death, remyelination is no longer occurring. So that's a big difference between these two figures. I decided to use Hoagland and Mexaki's figure due to its elementary illustration of the interleukin immune cell interaction slash cascade. Granted, it's kind of elementary, but don't get me wrong, it is very complex. So following antigen presentation to our CD4 positive T cells, the pro-inflammatory CD4 positive cytokines include interleukin 17, 21, 22, as well as interferon gamma, tumor necrosis factor, and then Kashkal and Allen in 2018 also suggest that these interleukins play a role in the inflammatory response of multiple sclerosis as well. Those being interleukin 1, interleukin 10, interleukin 16, interleukin 6 right here, as well as macrophage colony stimulating factor, or GM-CSF. And these cytokines previously mentioned are pro-inflammatory, as well as they're very toxic to oligodendrocytes, so they'll actually help in killing off those OG cells. And then as well as they have a role in increasing vascular permeability, which is going to increase the recruitment of other immune cells. That's pretty self-explanatory. An interesting takeaway from Hoagland and Mexaki that I kind of just wanted to include stated that there are actually two additional routes for these immune cells to actually enter the central nervous system, and those two methods being entering via the blood cerebrospinal fluid inside the choroid plexus, and then as well as entrance via the meningeal arteries. So I thought those are two cool takeaways just to include. So shown here in front of you is a biannual analysis of relapsing remitting multiple sclerosis via MRI imaging. And as time progresses from left to right, you can see in the superior period more and more white spots occurring. And these white spots are known as hypersensitivities. And hypersensitivities are really cool. I actually learned about this thoroughly when researching my presentation. But these hypersensitivities are actually going to occur when there's some sort of nonsense going on inside the brain, physiology. That can include inflammation or, say, a change in fluid concentration inside the brain. And then as well as white spots, if you take a closer look, you can actually see black spots arising too. And this is illustrating the degradation of white matter in the brain from those immune cells actually deteriorating it. And Hammer et al. In 2011 reminds us that this white matter degradation is actually going to result in the disturbance of signal transmission between those axons, and is going to result in a variety of neurological functions ranging from acute to absolutely devastating chronic symptoms. Shown here is really cool, is a light microscopic cross-section of a normal nerve section. Here is a nerve section exhibiting little to no myelin across the axons, versus in this section A, there's a large, thick amount of myelin across all of them. And then in contrast, the A and B, C actually illustrates what remyelination might look like after symptoms or deterioration of myelin may occur. So this is actually the same person in section A. There's just less myelin, which is going to result in less efficiency of their signal transduction. So I wanted to use Honin's illustration of the different patterns of multiple sclerosis. I think it's very, very useful in aiding our understanding of the disease. So 85 to 90% of multiple sclerosis patients are going to experience a relapsing and remitting pattern. And this is when patients typically recover entirely from symptoms, but signs and symptoms can actually begin to reside and compile as remyelination actually begins to occur. So you might experience symptoms, but you're going to get better. Time goes on, you experience some more, but then they start to reside and stay with you and kind of deteriorate the quality of life. 40% of these individuals will transition into the secondary progressive state, and patients will begin to patient symptoms increase over time with or without relapses. So here we see a relapse back to no symptoms, but then it's very possible that they don't see a loss in those symptoms. So this is extremely devastating in my opinion, as well as sad. And then 10 to 15% of these uh, patients are going to develop a primary progressive state. And this is when patients experience increasing symptoms with no plateaus or no improvement. And in my opinion, this is extremely overwhelming and sad as well. The symptoms and signs of multiple sclerosis are unparalleled in variation to other central nervous system diseases. What that means is that symptoms are absolutely they depend on person to person, and what actually makes MS unique is that a primary strategy in diagnosing MS is actually the compilement of symptoms. So they'll actually look at where these symptoms are occurring and maybe use those symptoms to predict where those plaques and locations are being affected. And I wanted to talk to you guys a little bit about symptoms experienced. Symptoms are not limited to these, but these are rather the more commonly experienced symptoms. And those include uh, double eye loss. You can lose sight in one eye. You can develop dark spots. You can develop double vision, also known as diplopia. Chronic eye pain is also known to be developed, as well as nystagmus, or the rapid oscillation of your eyeballs, which was, in my opinion, is very, very overwhelming. And then as well as chronic fatigue, depression, limb numbness and tingling, loss of motor function and coordination, and then as well as the complete loss of sexual desires. Currently in 2021, there's no silver bullet for this disease. The primary goal in treating individuals who experience MS is based upon minimizing and treating exacerbations, and then delaying further demyelination and efforts to reduce chronic symptoms. Disease-modifying treatments, or DMTs, such as interferon beta injections or treatments, are known to provide relief of onsetting symptoms, as well as corticosteroids are known to be a common medication. But some related research pointed that corticosteroids can be actually neurotoxic in high concentrations in humans. So actually did not include that one. Lastly, in closing, I wanted to tie a real life experiment or experience with the disease in order to demonstrate the emotional distress that multiple sclerosis will actually create. Um, and these two quotes are from an active MS survivor named quote unquote Jamie, who actually hides her real identity for some personal reason. But Jamie, I read a little bit about her blog, and it was absolutely gut wrenching. And it just made me kind of emotional. And I was kind of just sitting here in my normal everyday college life, and it just made me relate with her struggles and experiences. And it sort of made me want to really in depth understand this disease, because from what she kind of posted and talked about, she strongly believes that awareness should rapidly increase in both the social and medicinal environments. And I honestly couldn't agree more. So um, this was the end of my research. I hope that you guys all had a basic understanding of what was presented, and that it sticks with you throughout time. Thank you for your time, and God bless. Thank you.